Good morning, everyone. Welcome to the second day of the Cortisol Summit, specifically the Carney Complex track of the Cortisol Summit. And applause! Yay! I actually had a very long introduction planned, but I think literally our speaker doesn't need an introduction. This is someone who has done the research and knows Carney Complex better than anyone else in the world. You want to hear from him more than you want to hear from me, so I'm going to step aside and allow our amazing speaker, who we are so excited to have here, give us the latest on Carney Complex. We're so honored that he was able to join us. So
I'm delighted to be here. It's been now 7 years that I was a bearers. This was a couple of years after we cloned the gene for acromegaly, and I was invited to give a speech here. So I'm delighted to be here, see Kevin. I'm excited to be in this group with this group. The Carney Complex has been the project I chose as a fellow in 1994. And I wrote a short letter to Dr. Carney that, hey, I'm a genetics fellow at the NIH. I'm funded by NIH, and I have to choose a project for my fellowship, and I chose to find the gene for your disease. And he was obviously so naive. He was, a great clinician, but he knew nothing about genetics. And so he didn't answer. I was so disappointed, but ran into him at a meeting, and I said, hey, I'm the guy. He didn't remember the letter. He said, I didn't want to answer the letter until I got to meet you in person. And that's when the whole thing started. That was midsummer 94. So I wrote the letter in February 94. And by 1996, we knew the location of where the gene would be. And then it was 3 years later when I found the gene. How can I advance the slides? So this is what I don't want to. My talk here today is updates, right? And you want to know new research that I'm still engaged in with regards to carnase, and I'll show you what I'm doing right now. So I'm not going to go with the past. I'm not going to do the clinical carnase things. I'll show you what I'm doing right now. Obviously, refer to some of the things of the past. And then at the end, I have a few, I think, urgent clinical matters with regards to carnase that need new research, really starting from the beginning to try to find what I'm going to show you are very important new discoveries that need to be made so that the life of the patients with carnase will be better. Okay, so this is what the gene is. Okay, when I found it in 1999, it was the first gene to be found linked to a human disease of this pathway, which is perhaps the first molecular pathway to be linked to endocrinology, metabolism. It has so far given 6 or 7 Nobel Prizes, depending on how you count the Nobel Prizes. This is the cyclic AMP signaling pathway. Almost every signaling in the body involves cyclic AMP, either directly or indirectly. And PRK1 alpha, the gene for carnase, was the first gene to be found mutated, responsible for a human disease of this enzyme. Now, in 1989, 10 years before I found the gene for carnase, a gene called GS-alpha had been found, this one, GNAS, in the same pathway in another disease that's very similar, but it is not inherited, McCune-Albright syndrome. So in 1989, GS-alpha or GNAS was found linked to McCune-Albright syndrome. It is similar to carnase. The patients get muscular tumors, they get bone tumors. Actually, the muscular tumors are close to myxomas. They get bone tumors very similar to carnase osteochondral myxomas. The McCune-Albright have fibrous dysplasia. They get skin lesions, but not the same, not glandigenous. They get café au lait spots. And they get ovarian overfunction, they get thyroid overfunction, they get parathyroid overfunction. So there are, and they get Cushing syndrome, but not the adults, only the kids with McKinnon-Bride. And as I said, it's not inherited because this mutation showing you the importance of the pathway is not compatible with the live embryo. So if you have this mutation in all your cells, the embryo gets aborted. Imagine a single mutation in a gene in this pathway kills a human embryo and mouse as well. This experiment has been done in mice now as well. So it shows the importance of the pathway. So the people that get McKinnon-Bride are mosaics. They don't have the mutation in all their cells, and they cannot pass it on, obviously. 1999, we found the mutation in carnase. Similar disease as I explained, but this is not inherited. It can be passed on. And the reason it is milder, if you want, because it's compatible with life, it's because this gene is one of four that bind to this gene, which is called the catalytic subunit. So this gene of carnase is a regulatory subunit of an enzyme called protein kinase A, and four regulatory subunits, and I'm doing work on all four regulatory subunits still today. And all of these four are bound to catalytic subunits, of which the most important one is PRKC alpha, but there are three more catalytic subunits are expressed in other tissues. So it's a complicated pathway, but it's also simple if you remember that basically any ligand, a hormone, a peptide, binds to the receptor activates this gene activates adenine cyclase, another enzyme. Adenine cyclase makes cyclic AMP. Cyclic AMP binds to PRK alpha, the gene for carnase, which is that way the receptor for cyclic AMP. Then that activates the catalytic subunits, or this one in this case, PRKC alpha, which phosphorylates surrogate genes, and hence you have the response to cyclic AMP, right? This response has to happen in the nucleus of the cell. So it actually, the PRKC alpha gets into the nucleus. So this is the Carney Complex gene, and then we found in 2014 mutations in the PRKC alpha and the catalytic subunit in adrenal tumors leading to Cushing syndrome. And Jérôme Bertherat may talk about that. This was work that I did with him. So just one more sentence about phosphodiesterases. I'm not going to talk about phosphodiesterases today, but I discovered them in 2006 linked to these diseases. Why? Well, because molecularly, phosphodiesterases are the end of the signal, right? So the ligand, again, stimulates the generation of cyclic AMP. Cyclic AMP leads to activation of PKA. PKA leads to activation of PRKT alpha, which then goes into the nucleus and mediates the response to any ligand. But that response has to end. Something has to eat up cyclic AMP. And what eats up cyclic AMP are the phosphodiesterases. And so we found mutations in PDE11A and PDE8B. As I said, I don't have the time to show you this data. They are causing similar things to carnase with regards, in particular, the adrenal. So kids with PDE11A or PDE8B mutations get micronodular cortical disease, along with many other genes. We're actually writing now a paper, which we hope we will submit to New England Journal of Medicine, with all the new mutations in the phosphodiesterases. Next slide, please. So the identification of the gene and then catalytic subunit gave us better understanding of how the adrenal forms cortisol-producing cells, as well as the development of the rest of the adrenal cortex. So I'm going to show you, since my talk is about update, next slide, why this was very important. We now today know that because of this discovery, that cyclic AMP is essential for the development of the adrenal in the human embryo and the development of the zona that produce aldosterone, zona glomerulosa, cortisol, zona fasciculata, and the adrenal androgens, the aldosterone and the androgen sulfate, which is the zona that reticularis, that is the last zona of the adrenal. Next slide. We actually generated mice where we showed that PRK1 alpha is essential for the development of the zona fasciculata. And then, in fact, it is zona fasciculata that forms first, and from there, zona glomerulosa forms. All of this is due to the discovery of the gene Carney's. So we were able to knock out the gene in mice. We were able to show that these mice get hyperplasia. And today we know all these things, which we didn't know. I mean, it's amazing to me as, I'm a geneticist, but I'm also an endocrinologist. And I started my work, my PhD is in endocrinology, not in genetics. And, 40 years after my PhD, today to say that aldosterone-producing cells are made out of cortisol-producing cells in the developing human embryo, that's fascinating. And all of this work to be made primarily because of the discovery of the PRK1 alpha gene. Right? So it's amazing. Next slide. Showing how all these pathways are linked. Next slide. Okay. So then we started looking at the other regulatory subunits. So this is work that's ongoing for many of these projects. And why am I showing this related? As my talk today has updates, because I don't know if the average patient with Carney's knows how important the disease is for human physiology, number one. Number two, I'm showing you this because as patients, you will see in some of the things I'm going to show you, certain aspects of Carney complex that are built into the disease that have nothing to do with PRK1 alpha itself. For example, next, we discovered, and that was in 2020, not too long ago, it's 5 years ago, that the other catalytic subunit of PKA called PRKC beta, these patients have mild developmental delay. Most patients with Carney's have anxiety or some kids are in the spectrum, not necessarily autism. But in this disease, which is similar because it causes some of the skin conditions, also causes some skeletal findings. But in this disease, you actually have real developmental delay. And this is a disease that is due to mutation in the catalytic subunit that is also part of the PKA, the same enzyme that is affected in Carney's complex. Next slide. And then the gene in Carney's, I told you, is PRK1 alpha. And then we discovered in 2020 and 2021, mutations in PRK1 beta that also cause adrenal tumors, but without any of the other findings of Carney's complex. So these patients get hyperplasia, they get adenomas, but they get nothing else. So you have PRKC beta, similar to Carney's, but with developmental delay. Carney's doesn't have developmental delay. Then PRK1 beta, so PRKC beta, PRK1 beta, nothing, not even developmental delay, just adrenal hyperplasia and adenomas. Next one. So these are essentially new diseases. Now, in Carney's, we get Cushing's, right? But it is not the classic type of Cushing's. Most patients that have Cushing's due to PPNAD, when they stand next to a patient with real Cushing's, with Cushing's that is due to either a pituitary tumor or Cushing's that is due to an adrenocortical tumor not related to Carney's, they can see the differences. What are the differences? There are differences in the deposition of fat. Patients with Carney's, for example, get much less visceral fat than patients with regular Cushing's. And we found out all this because we were able to study the mice that had PRK1 alpha mutations, study the way they behave, study the way they deposit fat, and study the way they eat and exercise. Next slide. So, for example, mice that we knocked out the regulatory subunit PRKR2 beta, PRKR2 alpha, sorry. And why R2 alpha and not R1 alpha? Because R1 alpha, which is the gene for carnase, is expressed everywhere. And we could not isolate the function of R1 alpha in the pituitary or in the brain. So we looked at R2 alpha because it's expressed in specific places in the brain. We knocked it out. And what happened to these mice? They avoided sugar. You can see up there. They got, when we expose them to sugar and fat, they got less obesity. And number 3, which you can see here, we threw a wheel in their cage and they started running like crazy. So these were the perfect mice. They ate less and they exercised more. And they did all of that willingly. In carnase, we have, when we have R1 alpha down, because we have a mutation, we have R2 alpha up. Okay? When you knock out R2 alpha, you eat less and you exercise. So when your R2 alpha is up, you eat more and you exercise less. So part of what happens in patients with carnase is that they have more R2 alpha, which means that they can't avoid cravings. Whereas if you knock out R2 alpha, you can avoid at least the sugar cravings. And they can't get the will to exercise because they have a lot of R2 alpha, because we know that when you knock out R2 alpha, you exercise more. Why is all of that happening? Next slide. So we published this in JCI in 2020. Now, the reason that all of this is happening is that R2 alpha is specifically expressed in a part of the brain called the habenula. Habenula is a very small part of the brain, right in the center. And it regulates all our cravings. It regulates many of our addictions. Alcohol addiction, nicotine addiction, cocaine addiction is regulated by the habenula. Our response to pain is regulated by the habenula. And obviously our addiction to food and exercise, because exercise can be an addiction. I have. I need to run every day. And I do it for 40 years. And it is crazy how I feel when I don't run. So all of that's regulated by the habenula, and the habenula is the place where the R2 alpha gene is expressed. And so now we know, because of all this work, that carnase patients, because they have a bit too much R2 alpha expression because they lack R1 alpha, which compensates, so R2 alpha compensates for the lack of R1 alpha. They have what I told you before. They have this tendency for addiction, this lack of resistance to cravings, and but lack of will to exercise, at least with regards to the effect of R2 alpha and the habenula. This is all new work that has been done in the last 5 years in my lab. As a result of this, we also studied the regulatory subunits in the population, and we found, for example, that certain mutations like this one, the R115K mutation, which is overrepresented in African Americans, can have different effects with regards to metabolism. So these mutations regulate in the regulatory subunits, regulate the way we respond to metabolic syndrome. I'm not going to spend more time on that. Next slide. So all of this is relevant for human physiology. But the goal of the next slide. So this has a little bit of animation. So the next goal of all of this work is, of course, to try to find medications to help patients with Carney's, based on everything I just told you. Next slide. So translate this work to molecular therapeutics. And so basically, I started this work in 1990s. It's, we are somewhere here, and you can see the cloning of the genes that took place basically until now, until 2021, 2022. And now I'm moving to therapeutics. Next slide. And based on everything I told you, the most obvious target to provide a medication for Carney's is the catalytic subunit of the enzyme. Remember the pathway where I started? The regulatory subunit regulates the catalytic subunit. And everything I told you so far is about what the regulatory subunits do. But the regulatory subunits cannot do what they do without the catalytic subunit. So it's an obvious target. And what this shows is that and this is obviously a fly, and this is what happens to the fly when you activate the catalytic subunit of the pKa. It's actually compatible with life. Remember what I told you about the other mutation that was not compatible with life? This one is compatible with life. The embryo fly gets born as a fully formed fly. Well, it's not healthy, but it can't fly, and it dies within a minute after it's born, after it transforms to a fly. So this mutation, this overexpression of the catalytic subunit, which every patient with Carney's experiences, this is the result of the mutation. That's what the mutation of PRK1 alpha does. It activates the catalytic subunit. When you overexpress the catalytic subunit in the fly since birth, the organism forms, but it dies within hours after it's fully transformed to a fly that's supposed to fly. Next slide. So it's an obvious target for me, for anybody who works with Carney's, for anybody who works with this pathway, the cyclic AMP signaling pathway. It's an obvious target to find a medication that will block that catalytic subunit activity. And it will not have to be fully blocked. It will have, you can block it in a dosage, and I don't have the time to show you, but experiments we did in flies showed that this response I showed you there is dose dependent. So the less catalytic subunit activity, the more compatible with life it is. The more catalytic subunit activity, the less compatible with life it is. Okay? So next slide. So what I'm doing right now is treatment of hypercortisolism. Okay. So what I'm doing right now is trying to find the ligand, and let's go fast through the slides. It's the work we're doing right now to try to find the ligand. These are some molecules I'm working on to block the catalytic subunit. Next slide. We are actually taking advantage of the fact that the pathway is related to cyclic AMP, and we're using this as an assay. Next slide. And we're optimizing the slide, the assay. There is a mutation that we have that we're working with. Anyway, and this is work that's ongoing, and I hope that, I don't know, the next 5-10 years, there will be at some point compounds that will be available to block the catalytic subunit, and it will be amazing compounds because they will be useful for everything from cancers related to Carney's and unrelated to Carney's, anywhere where you have activation of cyclic AMP. It could be used in anxiety diseases, it could be used in addiction, it can be used for metabolic syndrome, so for a variety of things. Next slide. But then, of course, there's also the real problem of metabolic syndrome for patients with Carney's, as well as other patients with Cushing's, of course. And not all of these patients are candidates for surgery, as you know, because many patients with Carney's especially, but also true for mild Cushing syndrome, have either small hyperplasia or small adenomas, and you don't want to take the adrenals out. for small lesions like small hyperplasia, mild hyperplasia, or small adenomas. So one molecule that I started at the NIH, and now I'm running the trial in Europe, and hopefully we have approval from the FDA as an orphan drug designation. It's this medication called fluoxetine. I started work at the NIH, but then the pandemic, then I moved to Greece. And so we started the trial in Greece. We have now multi-sites in Europe, and hopefully we'll go back to the FDA for approval after we get approval by the European Medical Association, EMA. EMA and FDA have pretty similar rules. So hopefully if we get EMA approval, we can get FDA approval at the end again. What does fluoxetine do? It's interesting medication. So this is something that patients get today. And hopefully if we get the approval, it will become available for you in the next few years. Next slide. So this is not like in the previous work that was, it's still very preclinical. This is real clinical. And fluoxetine is a very interesting medication. It is a dihydroepiandrosterone sulfate analog. I want to remind you, if you don't know it, and I'd be happy to answer questions about this, that all patients with Carney's have very low DHAES levels. Okay, so this is a DHAES analog. DHAES in the human body is essentially a comparative antagonist of cortisol. It's a beautiful molecule. It's an androgen, a relatively weak androgen. It competes against the metabolic effects of cortisol without blocking the good effects of cortisol, the ones on inflammation and the ones on glucose, making glucose available to the tissues, which is essential for stress reaction. But it blocks the bad metabolic effects like diabetes. And it's therefore an anti-obesity medication. So that's DHAES. We made fluoxetine because fluoxetine doesn't have the androgen effect of DHAES, so that we can give a DHAES-like molecule that will improve all the metabolic effects, will not fully block the cortisol receptor, and at the same time will not give you extra hair growth or acne, which is the problem with using DHAES itself. So that's the good thing about fluoxetine. Next slide. So we've done now several studies showing that it is capable of blocking the bad effects of glucocorticoids. And here we compare it to dexamethasone and DHAES itself. Fluoxetine is much better in several tissues than DHAES, of course, than dexamethasone as well. Next slide. Fluoxetine, and apparently this is also a DHAEA effect, but fluoxetine has it a bit more. It's also a G6PD inhibitor. Many of you may have read the old literature about DHAEA being an anti-cancer drug and an anti-aging, has an anti-aging effect. And it seems that DHAEA mediates its anti-aging and anti-cancer effects through the inhibition of this enzyme, G6PD8. I don't want to tell you more about G6PD right now. But the point that I'm trying to make is that fluoxetine increases that effect of DHAEA, the anti-aging and the anti-cancer effect, through inhibition of G6PD. And so, next slide. The patients that get fluoxetine, you can see that here in mice, how we can treat certain cancers by using fluoxetine. The patients that were using it now experience less increase in their hemoglobin A1C, so they get less metabolic syndrome. And they absolutely have no problems with glucose utilization as well as adrenal insufficiency, so they don't get adrenal insufficiency. So this trial is ongoing. We have now recruited, this is a phase 2 trial. The goal is to do 24 patients in a crossover design. So 24 patients get treated for 6 months, and then they cross over and they become controls of themselves. So the whole study should be completed within a year or so. And we'll publish the data, let you know what it shows. Hopefully that will give us a preliminary approval to move on to a phase 3 trial. And obviously then we will advertise it widely so that, because we will need many more patients for the phase 3 trial. We have already recruited 6 to 8. I mean, 2 are being screened right now, so they may drop out. So we are 1/4 of our goal so far. So I hope that by the fall of 2026, the study will be completed. It's a great trial. So this is the medication, the first time that I'm actually doing a clinical trial with a medication that aims directly at the metabolic effects of carb. So this is the end of 2/3 of my talk. Basically going through all the new work that I'm doing with, just to give you an understanding of how important the discovery of the gene for carnase was, and then the ongoing preclinical work for the PRKC alpha antagonist, and the ongoing clinical work for trying to address the metabolic effects of Cushing's and carnase. And I'll finish my talk with 2 or 3 clinical issues in carnase that I have, one of them I have partly worked on, but I think it's critical that more answers are found, because the issues I'm going to refer to in this last part of my talk, I think require a bit more intense research. Obviously, because I'm an endocrinologist, I have focused my current work on the adrenal and metabolics and everything, but this next 2 are not endocrine. In part, one of them is, but are not. And so I'm not responsible for not initiating the work, because somebody else has to do it. Let me show you this. So I did a new search for my talk here, trying to see in PubMed what people are writing about carnase. Next slide. Well, let's go fast because I've told you this. So these are the major issues that remain unsolved. Okay, the first one, I think, very important, is myxomas. Today, when I started, myxomas and Cushing's were competing. When I looked at the data from the Mayo Clinic, from Dr. Carney's data before I found the gene, myxomas and Cushing's were competing for mortality. Patients with Carney's would die either because of a sudden stroke or an embolus from a myxoma, or from the complications of Cushing's. For example, I will never forget the 2 siblings that I got the first DNA from. One of the siblings, I got the DNA, and within a year, he was with the US Navy, got sick in the Philippines. And before he got sent back for a stupid hernia operation, and before he got sent back to the United States to get the operation, he developed sepsis, because obviously he had mild Cushing's, he was immunocompromised. They didn't take good care of him in the Philippines. And before he got transferred back, he died. He died of complications of sepsis. And this was mortality due to Cushing's in carnase. Well, today, primarily because of our work all these years, I don't know of any patient with carnase and Cushing that died due to complications of Cushing or immunocompromised Cushing's or the metabolic effects. I don't know. Maybe there is somebody I don't know, but in our records, we don't have any in the last 20 years. maybe 10 years. There's one patient that a kid that didn't have Carney's, but died of complications. But had everything else, and the gene was not here to allow. But patients with myxomas still die. And we haven't made any progress in the last 25 years on solving this issue. What I've done, I'll show you what we've done. Next slide. Obviously, because we have the data, we now know how to increase surveillance and prevent death. Not the development of the myxoma, which is really what needs to happen, hopefully with the medications I'm working on. But we can prevent that by knowing when to increase surveillance. For example, I don't know if you've seen this paper. This was published in 2021. This is all our collective experience with myxomas. We now know that if you have cutaneous myxomas, you are 40% more likely to get a heart myxoma. So you know that the patients with cutaneous myxomas or breast myxomas will need to get their heart ultrasounds every 6 months, sometimes every 3 months if they have small lesions. Whereas every other patient can afford to wait a year. Okay, so that can save a life. We now know patients with pituitary adenomas, and pituitary adenomas in Carney's are only growth hormone producing, rarely. So I routinely get questions from all over the world. Well, sometimes I have patients with Carney's and myxomas. Is there a medication I can use to prevent the development of another myxoma? And then my answer to this is the growth hormone high, or is IGF-1 high? And this is all our work. Because look at this, 50% higher chance of recurring myxoma if you have pituitary adenoma. And so there's certain conditions, and we can talk about what the conditions are. But there's certain conditions, high IGF-1, high growth hormone, I can talk more about details, that I say to these doctors that are writing to me and the families, you need to put your kid on a somatostatin analog to try to block the elevation of IGF-1. And then they say, well, what about the pituitary? Can I take the pituitary out? If there's no tumor in the pituitary, you won't take the pituitary out. Because most patients with Carney's don't have a visible tumor. What they have is hyperplasia producing growth hormone. So you don't want to take the pituitary out. Don't take the whole pituitary out? No. But you can block the growth hormone increase. And so hopefully that will prevent the recurrence of myxoma. I think that's the most important part of this. Maybe I should also say about the lentiginous. The higher the number of freckles, the more intense the freckling is, the higher the chances of a myxoma occurring. And I'm not quite understanding why, except that if it may be related to growth hormone, right? Because the higher the growth hormone IGF-1 levels, the more likely you are to get nevi and other pigmented lesions in the face. And so maybe that's related to growth hormone. So there's a link there. And another link I don't understand, but also it may be linked to growth hormone, is that if you do have thyroid nodules, for some reason that's also linked to a higher chance of recurring myxoma. Next slide. There's clearly a difference in genders. So next slide. You can see the differences there statistically, but let me read you the text. So in our study, the gender did not play a role in the initial appearance. However, 73% of the cases that experienced a recurrence were females. So it doesn't matter whether you're male or female with Carney's with regards to when you get your first myxoma, but it matters for getting a second myxoma or a third myxoma. Obviously, it seems that females get more frequently that second and third myxoma. Next slide. Which explains why there's a higher incidence of strokes in females. So the overall risk of developing the tumor by the age of 30 years was similar to male and female, 35%, 45%, but an increasing risk over time for females. The first event occurred significantly later in women compared with men. However, nearly all recurrences, what I just told you, occurred earlier in women than in men. A recurrent event rarely happened more than 8 years after the initial occurrence in men, and 17 years. It's striking differences, and probably have to do with hormonal dependence of these myxoma forming cells. So in men, follow-up may be needed more frequently for the first 8 years after the initial event, right? So this, we've made progress in the surveillance. We now understand that myxomas are more frequent, recurrent myxomas are more frequent in females, we even know when to expect them. We now know the dependence of this myxoma forming cells to growth hormone and IGF-1. So this is one of the few tumors anywhere in the human body that responds to growth hormone. Amazing, because people were looking for tumors that respond to growth hormone. Myxoma is one of them, and it's one of the few examples where we have documented of a tumor growing in response to growth hormone. Excellent. But the real progress that has to be made here is two things. One, and I'm not a cardiac surgeon, so that's why I said I haven't initiated this work. It has to be done. The first one is to develop effective tools to remove the myxomas without doing an open heart surgery. So this is a paper that was published last year. I was excited to see it. It's from Houston, Texas. Obviously, they have a good cardiovascular history of great cardiovascular surgery there. And I don't know how whether it is generalizable as a finding, but it's on the right path. But and if you read the paper, see the next slide, you will see it's just a single case how they removed the tumor, and they show that they were able to take all the tumor out. That's the problem with using catheters to remove the. That's why surgeons up to now are doing open heart surgeries, because these tumors, you can see how fragile they are, and the argument for doing open heart surgery all these years is that you can't safely remove all these little pieces without doing an open heart surgery. If you play around with a scope to try to get this tumor, you will inadvertently break out small pieces that will then embolize. Okay, that was the argument. Apparently, these guys were able to do it, and that's why they show how through the catheter they were able to select the entire tumor, and then they show it out when it's out, that they were able to remove this tumor without any piece breaking out. The tools they used are tools that are in existence, but what I'm arguing is there has to be a more focused research to develop robotic surgery that will be able to do all this somehow. I'm not a cardiac surgeon, so I don't know what I'm talking about, but somehow, so that this is now done without an open heart surgery. Right now, we know that all patients with Carney's can only have up to 5 open heart surgeries for removal of myxoma. After that, only heart transplant will save. And so far, there have been 2 heart transplants in patients with Carney I know of, one of them unsuccessful. So the patient died shortly after. So we are in dire need of essentially a technical discovery. This is not medicine per se. It's nothing like what I've shown you so far, like the things I work on. This is it's robotics. I don't know what it is. It is something that it's a technical thing. You're an engineer. We need a medical engineer that will come up with AI tools to, and obviously, almost certainly will have to be done using robotics to remove this tumor safely. So that's, I think, a very important issue that has to be done. The second one is the prevention of the formation of the myxoma, hopefully with the medications I'm working on, perhaps with other substances, clearly with the stopping the growth hormone from acting on these tumor cells. The next clinical issue is this tumors. Malignant melanotic nerve threat tumor. By the way, this is the new name of this tumor. Given to what I published on and Dr. Carney published on, a tumor we called back then pigmented schwannoma or melanotic PMS, pigmented melanotic schwannoma. So you will see it in my publications and in Dr. Carney's publication, PMS. Since 2021, I think, the WHO, the World Health Organization, renamed that tumor to malignant melanotic nerve threat tumor. And I think it's a mouthful, but you just have to familiarize yourself with that new name, because when you talk to oncologists, the new generation of oncologists will know nothing about PMS. And it's hard for somebody who doesn't know the literature to identify these two tumors as one. This tumor occurs in about 10 to 15%, maybe 10%, I shouldn't say 15, 10% of the patients with Carney complex. It's a tumor that when it's a primary and it's non-metastatic, it may or may not cause problems depending on where it is. This one is right on the spinal cord. So this one clearly causes problems. But there are melanotic schwannomas that are in the stomach, for example, or in the somewhere in the abdomen, and most of the time they don't cause problems. And you need to watch them though, because unfortunately, about half of them at some point become malignant and they become cancer. And when they metastasize to two sites. And once they are there, death is certain within a year or two. So they metastasize to the lungs and to the central nervous system. Right? And I've had patients that died of metastasis to both sides. Not at the same time. I had a lady who died of mets to the lung or two. And then I have one boy, 19 years old, who died of mets to the brain. To this day, 45 years after the discovery of the first PMS by Dr. Carney, there's no treatment for this. Once it is metastatic, there's no treatment. Next slide. This is what the tumor looks like. That's why Dr. Carney named it melanotic schwannoma. It's truly black. I think I've seen one or two cases. I actually went to the OR myself for patients with Carney's. Nobody, no surgeon, no pathologist, and I had never seen anything like that before. These tumors are like, they ooze ink. It's like calamari. You cut it out, it oozes ink. That's why Dr. Carney named it melanotic. It's melanotic, but I'm not exaggerating, it's black. It's completely black. It oozes ink. Never seen anything like this. There's nothing else that does that. No other tumor that I know does this. Very ugly tumor. Right now, the only treatment is surgery. The boy that died, the 19-year-old who died of mets to the brain from this tumor, he had an autopsy. And when they opened up his spine, black, the cerebrospinal fluid was completely black. It oozed out black. Horrible. it's a very aggressive tumor. And there's no chemotherapy that responds to. Some oncologists say that you should radiate after you take the tumor out to avoid the spread. If you get it, and it has meds, I don't. I get questions all the time. What's the most effective? It's not true. So it's urgent need to. So the next slide is the only advancement. Very good question. I didn't pay you. So the only advancement that has been made in the last few years is that now we know that it is identifiable by PET-CT, and this is from a recent paper that shows a relatively big one. You can see it right on the spinal cord there. I mean, most of these tumors are along the spinal cord, and that's why I recommend for every patient with Carney to get a full spine MRI every 5 years during the productive age, and who knows how frequently after the age of 50. And I'm saying during the productive years because, like other melanotic tumors, melanomas as well, these tumors seem to be responsive to hormonal stimulation. Again, they're more frequent in women than men, but both sexes have them. So during reproductive years, once every 5 years, and if you do have a lesion, there needs to be monitored every year to avoid seeing a patient 5 years later full of meds. What would you do if the original tumor metastasizes? Well, you try to take the med out right away. That's at least what we did with a couple of patients where we identified with surveillance and PET-CT. These tumors probably prolonged their life. I don't know if obviously we didn't cure them, but we prolonged their life by taking out the meds as they were coming out. Next slide. We just recently updated the recommendations for surveillance. So this is a paper that just came out, 2025. You can see me there. It's along with a number of other conditions that lead to endocrine tumors. So if you want the most recent update on surveillance, this is the paper. But my old papers are pretty good too. Next slide. This is my just the two final slides. This is a consortium I run now. I'm the head of the Precision Medicine Consortium for Greece. Next slide. You can see that's my new lab. That's the headquarters of the research institute, and this is the building. There is my lab. We don't do research in kinase. I mean, we obviously screen the PRK alpha mutations, but this is a molecular oncology consortium, so we do everything. All the breast cancers, all the prostate cancers. So we obviously have to deal with the common cancers in Greece right now. But it's working very well. I'm proud to say that November 18, our consortium got an award for our service to the Greek nation, and it's going to be presented on November 18 at the Black Tie dinner in Athens, and so I'm delighted. So next slide. Thank you very much for attending. This is my private clinic, and so I do offer consultations. We have to charge for it, but it's not like NIH. But this is my email, obviously for short questions and things like that. But if one wants a full consult with full review of all the pathology, all the films and everything, because I have staff that does it, we have to charge. But this is my email, so questions, anything, I'm traveling quite a bit. I have many responsibilities, but I'm pretty good at answering emails. If I don't answer within 24 hours, then I'm traveling. That's it. Thank you.
And we also brought some of your flyers.
Oh, thank you. Yeah, so one of the new positions I have now is we had a research institute at it's based in Tampa, so I'm actually heading to Tampa tomorrow. This is you may have heard it. This is the HCA Hospital for Endocrine Surgery. It's part of the HCA healthcare system. It's a private hospital, magnificent facility. Dr. Carling there is our adrenal surgeon, and he specializes in partial adrenalectomy. So it's very hard to find partial adrenalectomy around the world right now. And obviously, I'm biased in that I'm the head of the research institute, but I'm supporting this research because one of the things that we were not doing all these years was partial adrenalectomy. And I'm delighted that at this facility, where we offer great outcomes for a procedure that is relatively rare, for which there is no experts except for Dr. Carl, who's a street in Florida. And so you know that's the place that if you're interested, and if you know people that need partial adrenalectomy, you can write to me and I directly provide us. Thank you.
Thank you, Dr. Stratakis, so much. That was amazing. I got teary-eyed in certain parts of it. I don't know if anyone else did, but it was amazing getting all of that information and then update.